Good afternoon, everybody. And I think Dr. Vinita very clearly pointed out that you have to be choosing the right surgery depending on what you want in your patient and what all other risk factors and what is the comorbidity that patient has in his eyes along with glaucoma. And what I will be talking about is how do we enhance the outcome of trabeculectomy by taking appropriate steps during preoperative, intraoperative, and postoperative period. Now, I think glaucoma is we all know is a silent disease, and patients have no symptoms. So, whenever we are subjecting a patient to a glaucoma surgery, what they actually want is good vision without any medication and a comfortable eye. And what glaucoma surgeons want is a nice filtering posterior low-lying bleb with good intraocular pressure control without any medication from day one to almost maybe 10, 20 years and maybe beyond that. And what we actually don't want is any kind of complications, whether they are simple complications like hypotony or shallow anterior chamber. But what we actually dread is the vision-threatening complications like the suprachoroidal hemorrhage, the wipeout phenomenon, the leaking blebs or the blebitis or bleb-induced endophthalmitis, and the bleb failure. And I think all of you would agree that hypotony is one of the most important factor which is responsible for these vision-threatening complications. And when we talk about hypotony, it is the suddenness of hypotony which is happening during intraoperative period or the duration and the extent of hypotony which plays a very important role. So before we plan a glaucoma filtering surgery, it is very, very important for us to identify the eyes which have high risk of developing these vision-threatening complications. A patient who has advanced cupping like this, or maybe who has advanced visual field defect with the splitting of visual field can have, sorry, where's the pointer? So these patients are at more risk of wipeout phenomenon. So you have to take care that avoid hypotony at each and every step of your surgery. Now, preoperative assessment is again very important. All we want is a pristine, untouched conjunctiva. So if patient has had any kind of prior surgery, whether it's a penetrating keratoplasty, a VR surgery, which makes the conjunctival dissection very difficult, and the healing becomes more aggressive. So you have to be using antimitotic agents in such eyes. Again, you have to be careful in patients who have thin and inflamed conjunctiva. So it's always a good idea to check for the motility of conjunctiva using a wetted sponge before surgery. Now again, treating ocular surface is very important because these patients are on long-term anti-glaucoma medication which leads to a lot of ocular surface disorders, the dry eyes. So treat blepharitis, put the patient on copious lubricants, and if possible, give the patient a drug holiday from the anti-glaucoma medication, especially if the patient is on PG analog, pilocarpine or Ripatec, which we have started using recently. It's a good idea, if possible, give a 3 to 7 days withdrawal from these drugs. And put the patient on oral anti-glaucoma medication, but you have to be careful that when you put the patient on these carbonic anhydrase inhibitor, tell them about the potassium intake. You can tell them to eat more bananas or tomatoes to keep a check on the potassium levels. And again, if you feel that the ocular surface is highly inflamed, it's a good idea to start a low-dose steroid 1 week prior to surgery. Now again, both kind of refractive errors, whether it's a myopia, high myopia or high hyperope, can be associated with their subset of complications. So you have to be carefully looking into these parameters also. Now, good systemic control is something which we cannot ignore. We all know that high uncontrolled blood pressure is a known risk factor for a suprachoroidal hemorrhage and a wipeout phenomenon also. So we should always ask patient to have a good blood pressure control. Stop anticoagulants prior to surgery, otherwise you can land up in excessive bleeding and difficult suture removal or a suturolysis in the post-operative period if you're planning for that. Again, diabetics, you have to be careful because these have high levels of VEGF and can have aggressive scarring and poor wound healing and are more susceptible to develop infection. Now, once you have chosen the surgery and you're taking patient for surgery, it's a good idea to have a good intraocular pressure control, though I know that is the main reason why we are going to operate upon that patient, but in the perioperative period, it is good idea to put the patient on systemic anti-glaucoma agents so that you have a good preoperative intraocular pressure lowering. Again, operate upon a soft eye. You have to give mannitol almost half an hour to an hour before surgery. And do remember to give bathroom break, because otherwise during the entire surgical period, the patient will be squeezing and the surgery might become difficult because you'll have a lot of positive posterior vitreous pressure. Use as low volume of peribulbar as possible. If you are comfortable, you can use for a subtenon or a retrobulbar block. Avoid any kind of super pinky or vigorous digital massage, and during surgery you can use a lightweight self-retaining speculum, which again avoids the positive vitreous pressure. Now you have to have an excellent exposure in the area where you are going to make your bleb, and especially if you're planning for a tube surgery, you have to be giving a good exposure. So for this now, corneal traction sutures have become very popular, and very hardly we are using brittle sutures, which had their own complications. But whenever we are putting a corneal traction suture, take care that avoid full thickness entry or maybe too superficial a bite, which can lead to cheese wiring. And again, too wide a bite can lead to flap distortion and may interfere with the surgical precision. Now, coming to conjunctival dissection. Now, conjunctiva is a very, very sacred tissue, and we have to handle it very, very carefully. Avoid any kind of tooth forceps. So, hold the conjunctiva with a serrated plain forceps, and if possible, hold the tenons and retract the conjunctiva using a Merocell sponge. And again, after conjunctival dissection, tenon dissection is also very important, because if you leave the tenons undissected, it interferes with both the making of a scleral flap and also with the suture removal in the post-operative period. Now, we all want is a good hemostasis, so we have to be carefully, either you wait for your bleeders to stop in some time, or maybe do a very gentle non-charring cautery. Excessive cautery can lead to scleral thinning. So maybe do a select cautery in the area where you're planning an incision and a scleral flap. Now, antimetabolites have actually become a third hand of our glaucoma surgeons, and it has definitely improved the success rate of trabeculectomy in last couple of decades. But whenever we are using antimetabolite agents, we have to use it in the wider area, so make it as big as possible. Use multiple sponges. Avoid the edges of conjunctiva so that there is no bleb leak. Go as posterior as possible, and the time and the concentration of mitomycin can be used depending on the case that you are doing. So it can be varied from 0.2 to 0.4 milligram, and again the duration can be varied depending on the indication. And again, irrigate very nicely so there is no antimitotic agent left in the cul-de-sac. Now, Dr. Pencaw has very beautifully shown that posterior flow is all that we want, because we want to avoid the overhanging the anterior blebs, which can be associated with a lot of complications. And what we can do is to, even if you're choosing a triangular flap or a rectangular flap, it is a good idea to stop 1 millimeter short of limbus so that the flow becomes more posterior. After the scleral flap, the most important part of trabeculectomy is the sclerostomy, which is the crux of trabeculectomy. So whenever you are starting to do your sclerostomy, please place an apical suture. Now, these sutures help you in two ways. They help you to, you can tighten the sutures fast and avoid any kind of hypotony. And again, you can hold and have a better view of the area where you are going to make the sclerostomy. Pre-place a side port, because side port helps you to titrate the wound. It helps you to maintain the anterior chamber and maintain the intraocular pressure as well. You have to avoid either too small or too anterior or too posterior sclerostomy, and you have to be just anterior to the trabecular meshwork. Choosing a Vannas or a Cayley sponge is individual choice, and both work very well. Now, after you have done a sclerostomy, you have to make a peripheral iridotomy, which should be adequate size so that the sclerostomy does not get blocked by the thick iris, which are very common in Indian eyes. Now, after the scleral flap and the sclerostomy and the PI has been done, we have to do a thorough wound closure, which is very important, because we know that the blebs that seal well, they heal well and they swell well. So scleral flap suture is something which is very, very important. Now you can opt. Nowadays, what we want to avoid is hypotony at any stage. So whenever you are dealing with advanced glaucomas, you can go in, or even normal glaucomas, to avoid post-operative hypotony and shallow anterior chamber. It's always a good idea to a tight flap suturing. So you can go in for a suture lysis at a later post-op period, or a releasable suture, whatever you are comfortable with. Now, conjunctival repair is again, a lot of importance, because we have to seal each and every leaking point at the table. So if you are doing a phonics place flap or a limbus place flap, you can choose your sutures accordingly. You can choose a monofilament nylon, which works very well, or a vicryl. And again, if you have done a phonics base, a limbus based flap, you can suture the conjunctiva in 2 layers, tenon separately and the conjunctiva separately. And if you are in doubt, it's a good idea to use fluorescent to check for any kind of wound leaks, because they should be repaired at the table. Now, once you have done the surgery, it's always a good idea to cycloplegic the patient. So what I usually do is atropinize the patient and do a tight bandage. So in case if there is a slight ooze from the suture side, it can get self-sealed. And always put the patients on steroids, and steroids are usually required for a long time, maybe up to 3 months, and depending on the vascularity and the angry appearance of the bleb, you can taper the steroids as per the need, depending on how the bleb is behaving, along with the antibiotic and cycloplegic complication. Now, once you have done a trabeculectomy, in the post-operative period, you follow up your patients, and if you're planning for a suturolysis or a suture removal and you've done a releasable suture, depending on the intraocular pressure, you have to titrate the timing of removal of these. So it's a good idea to wait for a week, because this is the time the bleb is settling in. There is a slight amount of inflammation or healing happening. So good idea to control the pressures if they're high with the anti-glaucoma medication, and do the suture removal after 5 to 7 days of trabeculectomy. So I think at the end, I would like to say that it is very important whenever you are planning your filtering surgery to identify the patients at risk, control their systemic factors nicely, achieve a good preoperative lower intraocular pressure, use a low volume anesthesia and go in for a good exposure, use a non-charring cautery and minimal cautery, and go in for a wider application of mitomycin C. Leave your scleral flaps 1 millimeter short so that you can have a posterior flow. Apply pre-place suture before you are making a sclerostomy, and titrate your wound. And at the end, achieve a watertight wound closure. And with this, you can achieve a good and a successful outcome of trabeculectomy. Thank you for your kind attention.